The initial infant exam establishes the infant's well-being and identifies any potential issue that may need further examination. This assessment begins with a review of the current and past pregnancies, any prenatal screening tests performed, and risk factors for sepsis. Assessment should be performed for the presence of risk factors for neonatal sepsis. These include maternal intrapartum temperature greater than or equal to 38 degrees Celsius, membrane rupture greater than or equal to 18 hours, delivery at less than 37 weeks gestation, chorioamnionitis, maternal group B streptococcal colonization. There should be a low threshold for evaluation and treatment because of the potential for serious adverse effects, including death. It is important to understand the pregnant woman's birthing history as it can provide insight into risk factors for the current fetus. Gravida and Para are scoring tools used to easily understand the birthing history. Gravidity, or gravida, is the number of times the woman has conceived. This number should include the current pregnancy. Parity, or para, is the number of times the woman has given birth to a viable infant. Sometimes, only gravida and para numbers are given, but this can provide an incomplete picture. For example, if a pregnant woman presents in labor and her birth history is described as G2P2, we can assume that she has conceived twice and birthed 2 children after 20 weeks gestation. If she was G3P2, we could assume that she has conceived 3 times and either has 2 living children from 2 pregnancies, 2 losses with 1 twin pregnancy, or is on her 3rd pregnancy and both of the previous children survived. For this reason, parity can be broken down into different categories when the information is available. The acronym GTPAL provides more complete information about the birthing history. G remains the number of times the woman has conceived and carried to any gestation. This is not a count of the number of deliveries. Twin or triplet pregnancies are counted as a single pregnancy. T is term and refers to the number of pregnancies carried and delivered at 37 weeks gestation or more. If there are twins or triplets, each is counted individually. P is preterm and refers to the number of pregnancies carried and delivered between 20 and 36 and 6/7 weeks gestation. This number includes all deliveries regardless if the infant was born alive or stillbirth. A is abortions and refers to the number of known losses before 20 weeks gestation. This includes both spontaneous and elective losses. L is the number of living children. Let's practice with a few scenarios. A woman is on her first pregnancy and birthed a single child at 40 weeks gestation. This would be written as G1, T1, P0, A0, L14. 1 pregnancy, 1 term birth, 0 preterm births, and 1 living child. A woman on her first pregnancy and birthed twins are 38 weeks gestation. This would be written as G1, T2, P0, A0, L2 for 1 pregnancy, 2 term births, 0 preterm births, and 1 living child. A woman on her 3rd pregnancy with a history of 2 single-term pregnancies and both children are living and just birthed preterm twins. This would be written as G3T2, P2, A0, L44. 3 pregnancies, 2 term births, 2 preterm births, and 4 living children. A woman with a history of 8 pregnancies that were spontaneous abortion, currently presented pregnant with a single fetus at 28 weeks gestation and delivered. This would be G9, T0, P1, A8, L1. The APGAR score is a universally accepted rating system used to score infants' health in the immediate period after delivery. The scoring is named after the creator, Virginia APGAR, an American physician in 1963. The score is based on 5 variables and rated at 1 and 5 minutes after birth. If the 5-minute scores are poor, the scoring can be repeated at 5 minutes intervals or until resuscitation efforts have stopped. The 1-minute scores can be interpreted as how well the baby tolerated the birthing process. A low 1-minute score is not predictive of adverse clinical outcomes or long-term health issues. The 5-minute scores reflect the transition to extrauterine life and the infant's quality of resuscitation. Low scores at 5 minutes are correlated with increased mortality and may confer an increased risk of cerebral palsy. The variables included in the APGAR score are heart rate, respiratory effort, muscle tone, reflex irritability, and color. Each variable provides 0, 1, or 2 points for a maximum of 10. Scores of 7 to 10 are considered normal. Scores less than 6 indicate the infant is in distress. Here is the scoring system for each variable. Almost all infants will lose 1 point for color. However, many providers are superstitious about ever giving an infant an APGAR score of 10. After the infant has successfully transitioned, it should be evaluated for any major deformities. The infant should be given the eyes and thighs within 1 hour of birth. An antimicrobial agent into both eyes to prevent gonococcal ophthalmia. The ointment is usually 0.5% erythromycin. A vitamin K injection is given in the muscle of the leg to prevent hemorrhage disease of the newborn. Some countries may attempt oral vitamin K supplementation, but a single injection is much more efficient. Receiving the injection is important as it can help prevent serious complications related to bleeding, such as intestinal hemorrhage, intracranial hemorrhage with subsequent neurodevelopmental impairment, and possible death. Universal vaccination with the hepatitis B vaccine has caused the overall incidence of the virus to decrease by 75% in children from 1990 to 2004. It is recommended that all infants receive the hepatitis B vaccine. A first dose of the hepatitis B vaccine should be given to all infants born to hepatitis B negative mothers within 24 hours of birth. If the mother is hepatitis B positive, or has symptoms of hepatitis B and the results of the test are not available, the hepatitis B vaccine and hepatitis B immunoglobulins should be given as soon as possible and within 12 hours after birth. Newborn infants should have a full assessment performed within 24 hours of birth to identify any abnormalities that would alter the normal newborn course. The basics of physical assessment include keeping the infant warm during the examination, have the necessary equipment needed, calm the infant before examining, handle the infant gently, and redress or swaddle the infant at the conclusion of the assessment. The assessment begins before the infant if touched. The infant should be observed in the undressed, resting, non-stimulated state. This assessment included an assessment for obvious birth defects, nutritional status, respiratory effort, position and movement, and color. Next, the examiner should auscultate the lungs, heart, and abdomen. Palpitation of the head, abdomen, and hips is performed next. Lastly, a head-to-toe examination is performed including assessment of symmetry and reflexes. Vital signs should be recorded at regular intervals, such as every 30 to 60 minutes, during the first 4 to 6 hours of life, then every 8 to 12 hours. The normal vital signs collected for the newborn include temperature, respiratory rate, and heart rate. Physical measurements of the body are recorded and plotted against standards for gestation and gender. This provides information about the infant's growth and will be used as a standard to compare the infant's continued growth during follow-up appointments. Weight is measured on a standard scale. Length is measured from the top of the head to the bottom of the feet with legs fully extended. The use of a length board with 2 examiners can improve the accuracy of this measurement. Length and weight are used to assess skeletal muscle growth. Head circumference provides information about brain growth. To measure, the tape measure should be placed on the forehead and around the circumference at the widest possible point. This is repeated 3 times and the largest measurement is recorded. Head circumference can change significantly over the first few days after birth, as the birthing process can compress the head and cause edema. It usually returns to normal shape and size within a few days. Most neonates lose 7 to 10% of their birth weight during the first few days of life, primarily because fluid is lost in urine and insensibly and secondarily because meconium is passed, vernix caseosa is lost, and the umbilical cord dries. Exclusively breastfed infants delivered by cesarean section tend to have greater weight loss in the first week of life. The infant should return to birth weight within 10 to 14 days after birth. Excessive weight loss should be evaluated with a complete feeding assessment, ongoing lactation support for breastfeeding mothers, and interventions as deemed necessary. Calculating the percentage of weight loss is fairly straightforward. Determine the total weight loss, divided by the birth weight, and times 100 to make it a percentage. 3,000 grams at birth minus a current weight of 2,500 grams equals a weight change of 500 grams. Divide this by the birth weight of 3,000 grams gives 0.166. Times this by 100 to convert to a percent, and you have 16.7%. Growth charts provide the percentile curves showing the distribution of the selected measurement in children. They are used to track the growth velocity of infants and help identify infants who may be experiencing issues with growth, like malnutrition, chronic illness, or endocrine abnormalities. The World Health Organization provides growth standards for infants 0 to 2 years old with separate charts for boys and girls. The initial plotting of the measurements can provide information about fetal growth. Measurements will be repeated and plotted at each follow-up appointment with the primary care provider. Newborns should be fed early and frequently to avoid hypoglycemia. The frequency, duration, and volume of feeds will be dependent upon whether the newborn is breastfed or receives formula. Each feeding should be recorded, and if the newborn is fed formula, the volume of feeding should also be recorded. Breastfeeding is recommended because of its increased benefits for both the infant and mother compared with formula feeding, except when medically contraindicated. Successful breastfeeding is enhanced by putting the neonate to the breast as soon as possible after delivery. Spitting mucus after feeding is common but should subside within 48 hours. If spitting mucus or emesis persists past 48 hours or if vomit is bilious, complete evaluation of the upper gastrointestinal and respiratory tracts is needed to detect congenital GI anomalies. Minor variations in day-to-day food intake are common and, although often of concern to parents, usually require only reassurance and guidance unless there are signs of disease or changes in growth parameters, particularly weight. Birth weight should be regained by 2 weeks in breastfed infants, and earlier in formula-fed infants, and a subsequent gain of about 20 to 30 grams a day, or 1 ounce a day, is expected for the first few months. Infants should double their birth weight by about 5 months. Breast milk is the nutrition of choice for young infants, and is recommended for a minimum of 6 months. The introduction of appropriate solid food should begin at 6 months to 1 year. Beyond 1 year, breastfeeding may continue for as long as both infant and mother desire, although after 1 year, breastfeeding should complement a full diet of solid foods and fluids. Breastfeeding offers the infant nutritional and cognitive advantages. It can protect against infections, allergies, and the development of obesity, Crohn's disease, and diabetes. Milk production should be fully established by 72 to 96 hours in first-time mothers. The first milk produced is called colostrum. This is a special high-calorie, high-protein, yellow milk that is rich in antibodies, lymphocytes, macrophages, vitamin E, and omega-3 and omega-6 fatty acids. Any colostrum produced should be fed to the infant, even just drops, as it can help develop the infant's gastrointestinal flora, stimulate the passage of meconium, and transfer antibodies. The infant should be breastfed on demand or every 1.5 to 3 hours for 8 to 12 feedings a day. In the first few days, infants should be wakened and stimulated to complete feedings. Once feedings are established, the infant may sleep longer between feeds. Parents should aim for a schedule that allows the infant to sleep as long as possible at night so they can rest. mothers who cannot be present for all feedings should be encouraged to pump and store breast milk. Pumped milk should be immediately refrigerated if it will be fed within 48 hours. If refrigerated milk is not used in 96 hours, it should be discarded as there is a high risk for bacterial contamination. Breast milk that is not fed in the 48 hours after pumping should be frozen. Frozen milk should be thawed by placing it in warm water or a commercial warmer. Breast milk should not be microwaved as this can cause uneven heating and burn the infant. Formula is the only acceptable alternative to breastfeeding during the first year of life. The infant should never be fed water or whole cow's milk as milk is not nutritionally complete, and water can cause hyponatremia. Commercially prepared infant formulas are available in powders, concentrated liquids, and ready-to-feed liquids. Most are supplemented with vitamins, iron, and fatty acids. Cow's milk-based formula is the standard unless the infant develops any signs of intolerance. Formula feedings are on demand since it digests slower than breast milk. The infant should be fed 1/2 to 2 ounces every 3 to 4 hours, then gradually increase during the first week of life up to 3 ounces 6 times a day. The choice of formula should be based on infant tolerance and cost. Formula can become very expensive, and mothers may receive financial support for specific formulas. It is important that they receive the formula that is easiest for them to obtain and purchase. Breastfeeding offers many benefits over formula feeding, but ensuring the infant is adequately fed is the best practice. The Breast is Best slogan encourages mothers to exclusively breastfeed their infants. However, this became an ideology, and some mothers would let their infants go hungry instead of feeding the infant anything other than breast milk. This increases the risk that the infant will become dehydrated or develop hypoglycemia or jaundice. This also causes formula sharing and caused a great deal of pressure, stress, and guilt for mothers who could not produce breast milk or had a poor milk supply. The Fed is Best strategy ensures that the infant's nutritional needs are met and there are minimal risks for complications. The infants should be fed when they are hungry with whatever breast milk that is available, then supplemented with formula if the supply of milk is not sufficient to meet the infant's demand. Parents should be supported and encouraged to ensure that their baby is adequately fed. Because there is a chance that the infant could have congenital deformities of the urinary or gastrointestinal system, the infant needs to demonstrate the ability to void and stool. The first urine should occur within the first 24 hours of life. The infant will then urinate about once a day until 6 days of then 6 or more times a day of light to dark yellow urine. The first stool should occur within the first 48 hours of life. The first stool is called meconium. The next stools will be transitionary and appear dark green to yellow depending on feeding success. The stools should not be white, chalky gray, or pale yellow. This could indicate biliary atresia. If the infant does not pass urine in the first 24 hours or stool in the first 48 hours, it should be referred to the appropriate specialist. The timing of the first bath is uncertain. The expert consensus from the World Health Organization suggests that the first bath be delayed for 24 hours after birth, or at least 6 hours when 24 hours are not possible. This suggestion supports the idea that delaying the first bath allows the infant time for vital signs to stabilize after birth. Delaying the first bath also allows more opportunities for skin-to-skin care. Lastly, leaving the vernix caseosa in place may have benefits, such as moisturizing the infant's skin, allowing for better thermoregulation, and improved infection control. Baths should be performed immediately after delivery if there are concerns for transmittable infections. This include infants born with mothers with active herpes simplex virus, genital lesions, or a history of HIV or hepatitis B or C. Circumcision is the removal of the foreskin of the penis. It is mainly performed for a variety of religious, cultural, or medical reasons. It should be offered to all male families with the risks and benefits provided in a non-biased manner. An intact foreskin provides a warm, moist environment that can trap pathogens and bodily secretions. Removal of the foreskin keeps the head of the penis dry and less favorable for pathogens to survive and replicate. This leads to lower rates of urinary tract infections and sexually transmitted infections. Other benefits include lower rates of penile cancer and inflammation. The risks associated with circumcision include procedural pain, bleeding, infection, or injury. After circumcision is performed, a gauze dressing is applied. The gauze should be removed and replaced with every diaper change for the following 24 hours. The use of a lubricant, like Vaseline, can prevent the glands from sticking to the diaper. The penis should be cleaned with warm water and a cotton ball once or twice a day. After the first 24 hours, the gauze may be removed and the lubricant may be applied directly to the penis for 3 to 5 days. This helps keep the area clean and keeps it from sticking to the diaper. The penis will develop a soft yellow scab that will go away in a few days. If the penis develops any redness, swelling, bleeding more than a quarter size on the diaper, or drainage that does not go away, the parents should contact their healthcare provider. Newborn screening is important for the early detection of many congenital genetic and metabolic disorders, aimed at the earliest possible recognition and management of affected newborns, to prevent the morbidity, mortality, and disabilities associated with an inherited metabolic disorder. Screening tests do not provide a definitive diagnosis, but rather they identify newborns who require further testing. The disorders that are tested for are determined by the state health department. The blood spot panel is routinely performed on all newborns in the nursery. The blood spot specimen should be obtained during the birth hospitalization at 24 to 48 hours after birth. This timing optimizes the sensitivity of testing as it permits accumulation of abnormal compounds in the infant's blood and the best chance of obtaining a positive result if disease is present. Earlier testing, like within the first 24 hours after birth, is generally discouraged since it increases the likelihood of false positive test results. Blood samples are obtained by heel lance and collected on filter paper cards that are provided for this purpose. Samples are then sent to a central laboratory for analysis. The newborn blood spot panel typically takes 5 to 7 days to result, which are communicated to the provider who provides the family with the results. Hearing loss is one of the most frequently occurring birth defects, and is even more common in infants who are admitted to an intensive care unit at birth. All infants should have hearing screens performed at birth. The actual requirements of hearing screenings is determined by the state government, with some screening only high-risk infants, and other screening all infants. Infants that fail the hearing screen in one or both ears should have the tests repeated a second time before discharge. Vernix in the ear canal or middle ear fluid is responsible for about every 6 out of 10 failed screens. This fluid often goes away in the first few months of life, but sometimes it may need to be removed by a specialist. The test cannot determine the cause of a failed screen, so follow-up with a hearing specialist is required. Screening for critical congenital heart disease is part of the normal newborn assessment. Once the infant is 24 hours or more old, a pulse oximeter is placed on the right hand and another extremity. The screening is positive, or indicating a congenital heart disease if the oxygen saturation is less than 90%. The oxygen saturation on the right hand and foot are less than 95% on 3 separate measurements taken 1 hour apart. There is a greater than 3% difference in the oxygen saturation between preductal, or the right hand, and postductal, usually the feet, on 3 separate measurements taken 1 hour apart. Any infant with a positive screen should be referred to cardiology for additional testing and follow-up care. During the birth hospitalization, newborns should be routinely assessed every 8 to 12 hours and at discharge for the presence of jaundice. A visual inspection for yellowing of the skin is inadequate for determining the level of bilirubin in the infant's blood. Bilirubin levels should be monitored with a transcutaneous device or by total serum or plasma levels. The levels should be used with the infant's individual risk for developing hyperbilirubinemia to determine the need for evaluation and treatment. The infant's hips should be examined for developmental dysplasia of the hip. The Ortolani and Barlow maneuvers are the most reliable screening tests for evaluating hip stability. Although they are described as separate tests, in clinical practice, both maneuvers are done in a sequence, not as separate examinations. The sensation of dislocation or reduction is distinct and best described as a jerk, or clunk, and differs from that of benign joint popping or tendon snapping. Risk factors for developmental dysplasia of the hip include female gender, in utero breech position, and a positive family history. Early intervention is important in the treatment or correction of hip dysplasia, so it is important to recognize at-risk infants early. Infants with any risk factors or joint instability should have a hip ultrasound performed between 4 and 6 weeks of age. At delivery, the umbilical cord is cut and a clamp is placed on the end to prevent bleeding. Historically, parents and providers have tried numerous strategies to reduce bacterial colonization of the umbilical cord and the development of omphalitis. These strategies have not been found to reduce infection rates, but only increase the time it took for the cord to dry and detach. The best strategy has been found to keep the cord clean and dry until it naturally falls off in about 1 week, but it can take up to 3 weeks. Wetting the cord can extend the time it takes to fall off. If the umbilical cord is at high risk for omphalitis, like the cord was cut with unsterile scissors or the delivery was outside the hospital, it can be cleaned with an antiseptic then allowed to dry. If redness develops near the umbilical cord stump, it should be evaluated. The length of stay for each mother-infant pair varies depending on multiple variables. For the infant, the hospitalization should be long enough to allow providers enough time to detect any potential problems that could arise. This also allows the family time to prepare for continued care at home. In the United States, many states have passed legislation and insurance coverages to prevent extremely early discharge. Most places accept 48 hours for a vaginal delivery and 96 hours for a cesarean section. Most hospitals utilize discharge criteria to ensure that is prepared to safely transition from the hospital to home. At the very minimal, the infant needs to be able to eat, have a car seat and crib at home, maintain their temperature, heart rate, and respirations, and has passed stool and urine. Other considerations include completion and reassuring results of all screening and tests, support system and infant care supplies at home, and a follow-up appointment scheduled with a pediatrician within 48 hours if the length of stay was less than 48 hours or within 3 to 5 days if initial stay was longer than 48 hours. The parents also need to have a rear-facing car seat installed in their vehicle. Many hospitals provide support for installation. Parents should be reminded about the sensory ability of their infant. The infant can hear their voice and turn towards sounds. It can smell and recognize the scent of their mother's breast milk. It can see about 8 to 12 inches in front of them and fix on objects. They have more taste buds than adults and have a preference for sweet breast milk. Parents should be provided both verbal and written education in their own language and along with the phone numbers for local support and emergency services. Education should include danger signs and who to call. This includes if the infant has a fever over 100.4 Fahrenheit, breathing unusually or persistent cough, yellow skin, repeat vomiting or green vomit, or acting not right or seems off. Car seat education. Umbilical cord care. Bathing. Genital and diapering care or circumcision care. Breastfeeding at least 8 times a day or at least every 4 hours. Burp the infant after feedings. Some spit-ups is normal, but it should not be green-colored. Do not give the infant water. The infant should have 6 or more wet diapers a day. Infants sleep for 18 to 20 hours each day. Try to encourage regular sleep patterns for naps and at night. Keep the sleeping area at a normal temperature. The infant should sleep on its back, on a firm flat surface, close to you but never in the bed with you. Co-sleeping increases the risk for sudden infant death syndrome. Many hospitals have programs that provide free cribs to families in need. Keep the crib away from fans, air conditioners, or drafts. Do not allow anyone to smoke around the baby. Do not allow anyone who is sick come in contact with the baby. Always have others wash hands before touching baby. Wash own hands before touching the baby and after changing diapers. If the baby goes outside, dress in at least the same layers as the adult plus one. Never leave the infant alone with pets. Never shake the baby. Attend all follow-up appointments. Parents should also be given instructions about self-care and monitoring for postpartum depression for mothers, fathers, and other caregiver dynamics.